Hi everybody, a very warm welcome to all of you for joining us today. I'm Divya Sharma, and it's my privilege to anchor today's important and timely discussion on revolutionizing lung cancer care in India, the promise of precision medicine and early intervention. Now, lung cancer continues to be one of the leading causes of cancer related mortality in India. Yet, what makes this crisis even more concerning is how frequently the disease is detected at an advanced stage. Now, with changing lifestyles, rising air pollution, and also a growing number of non smokers, especially women being diagnosed, the lung cancer landscape in India is clearly evolving. Now, today's webinar aims to create clarity, awareness, empowerment for patients, caregivers, clinicians, and all stakeholders by discussing early detection, screening, diagnostic challenges, and how precision medicine is transforming outcomes. Now, we're honored today to be joined by an esteemed panel of experts who bring deep clinical experience and insight into lung cancer care across India. Now, to begin with, it's my pleasure to introduce Dr. T. Raja, Director, Medical Oncology, Apollo Hospitals, Chennai. He's the head of DNB Medical Oncology program in Apollo and an adjunct professor in medical oncology. A highly respected expert in lung cancer care, Dr. Raja brings a strong perspective on how molecular diagnostics and targeted therapies are reshaping lung cancer outcomes in India. Welcome, Doctor.
Thank you.
Next, we are joined by Dr. Bahl, Principal Director of Medical Oncology in Fortis Gurgaon. His work focuses extensively on lung cancer, epidemiology, screening, and impact of environmental and lifestyle factors. Now, Dr. Bahl will help us understand how air pollution and non-traditional risk factors are influencing lung cancer patterns, particularly among non-smokers and women. Now, we also have with us Dr. Tanmoy Mandal, consultant of medical oncology at Manipal Hospital, MD, and be a senior clinician with deep expertise in lung cancer diagnostics and treatment delivery, especially in diverse healthcare settings. Welcome, Doctor.
Welcome.
And we have joining the panel Dr. Jyoti Bajpai, lead medical and precision oncology at Navi Mumbai Maharashtra Region, Apollo Hospitals. She is also the founder and president-elect of Immuno-Oncology Society of India, who brings a patient-centric perspective to lung cancer care with special focus on early symptoms, supportive care, and lifestyle factors that influence treatment outcomes. Now, thank you all the doctors for joining us today. Let us now begin our discussion by understanding how lung cancer care in India has evolved and where the biggest gaps still remain. So now, Dr. Raja, let's begin with you. How has the lung cancer landscape in India changed in the recent years?
Thank you. The lung cancer landscape has considerably changed. First of all, we have to say that the incidence of lung cancer is increasing in India. Even in 1 decade, the incidence has almost doubled. The other thing is that the causes or the etiology for lung cancer has completely, changed. Earlier,
Okay.
we used to associate lung cancer exclusively to smokers, but now we are seeing that lung cancer is seen in non-smokers and in
Yeah.
women and also in younger people. And some important things have to be mentioned, particularly occupational hazards, the
Yeah.
industry we work, and air pollution, and also at home, the kind of sometimes there is an exposure to biomass fuel, and we are now being aware of genetic susceptibility, and these are the changes that have happened. The other thing is that earlier we used to routinely think about lung cancer as squamous cell carcinoma.
Okay.
Now, adenocarcinoma has become one of the most dominant histopathology.
Okay.
Apart from
So,
this,
sir,
in lung
for the layman, could you just tell me the difference between both of these?
yes, this is pathological varieties of lung cancer. Earlier, the incidence of squamous cell carcinoma was the highest among the pathology, but now adenocarcinoma is the probably the commonest pathology that we see in lung cancer. Why
Okay.
is it different? Because the treatment options and the drugs that are used for these pathologies are different. And
Yeah.
the other big changes that has happened is the with regard to the diagnosis and therapeutics. Earlier, lung cancer was diagnosed as a cancer and just by the pathology, but now we routinely look at lung cancer as a molecularly driven disease, and therefore we want to know everything about the DNA of the lung cancer. We now classify them according to the genetic changes. And then the
Okay.
treatment has also changed from treating every lung cancer as the same
Yeah.
to individual, personalized cancer care. Now we realize that each patient is different, and then we tailor the treatment accordingly. These are all the changes that has happened over the past 10 years in India.
Okay. So, Dr. Raja, when you also mentioned it started happening in way younger people. So, when you say younger, what age group are we talking about?
Earlier, lung cancer used to be, incidence is used to be in the age of about 50s and 60s. Now we
Okay.
are seeing lung cancers in the age group of 30s and 40s, particularly adenocarcinomas you see in the younger age group, non-smokers, and in women who don't have any other risk factors. You see these cancers at an younger age group.
Yeah, all right. Okay, Dr. Mandal, now, why do most lung cancer cases in India still present at a very advanced stage?
So see, as we all know that whenever we have symptoms for lung cancer, it's already an advanced phase. Means whenever the patient presents with hemoptysis, that means blood in the sputum, or breathlessness due to some pleural effusion, or multiple lung nodules in the lung mass. So it's already an advanced stage. Basically, that's the reason, because lung cancer, whenever it presents with symptom, it's already advanced. Then
Yeah.
is it that do we don't get any lung cancer which is an early stage or a locally advanced stage? Yes, nowadays which we are getting those also.
Okay.
Most commonly, how we do find is that whenever you go for some other surgery, suppose you are going for a gallbladder excision or something like that, and you do a routine chest x-ray which finds a shadow in it,
Yeah.
incidentally detected some cases of patients of lung cancer, those are mostly early detected. And yes, nowadays we are detecting some of them in the early stage also.
Okay, so what do you think is the reason? Is it that usually, like, if somebody is a patient of lung cancer, is it that they are not able to, figure it out because the symptoms are not very clearly out there until it has become a very advanced stage? Is that the usual reason?
Yes, actually, this is the actual reason, because if you compare a lung cancer with a breast cancer, so breast cancer is a superficial malignancy which you can feel with your hands, but lung cancer is a deep-seated organ which you can't see. You can't feel a lung lump within yourself. That's the most important challenge which we face. And if you ask cough is a symptom for even pneumonia, even tuberculosis, and many other diseases. So just having a 1 week or a 2 week cough doesn't make it a symptom of lung cancer. And we don't go for a CT or anything like that.
Absolutely. And again, as both of you mentioned, that so many people who are not even smoking are getting it. So probably a non-smoker, it will not hit the person also that probably I should go and get my, a lung X-ray done or whatever. Okay. Okay. Dr. Raja, who should be considered high risk for lung cancer beyond smokers in the Indian context?
In India, lung cancer risk factors can be called as multifactorial.
Okay.
There are a number of reasons other than smoking that can be attributed to lung cancers. For example, we need to be aware of ambient air pollution in the public places and in the big industrialized or urban cities, tier one cities particularly.
Correct.
I think there is a common knowledge, but we need to be aware of what we call particulate matter, which is air pollution level. There is
Mhm.
two terminologies known as particulate matter 2.5 and particulate matter 10. Particulate matter 2.5 is something that needs to be well known to everyone. There
Mhm.
are different levels wherein it can be considered as not safe or very dangerous and so on and so forth.
Yeah.
So that one is a risk factor. Other than that, people working in some high risk occupation, for example, mining, construction,
Yeah.
shipyards, cement
Yeah.
and textile industries, where there is exposure to asbestos and silica. So these are considered as high risk occupation.
Yeah.
At home, biomass fuels like wood, and coal and cow dung is still used in some part of our country. That's
Correct.
considered as a risk factor. And
Okay.
then second-hand smoking has to be emphasized. Passive smokers, I mean,
Yeah.
who get exposed to smoking at home when
Yeah.
someone else at home is smoking, children and women get exposed. And in
Yeah.
workplace, you are not able to say no to your friend or your colleague. Workplace
Absolutely.
setting,
Workplace,
these are
even
all
even I
important.
believe in restaurants also, it's become very difficult because so many places have normalized vaping, though it's supposed to be it's supposed to be illegal. But I come across so many restaurants which are okay with people coming in vaping within the premises, and people don't take it kindly, even if you want to tell them that please don't, we are inhaling the second-hand smoke.
Absolutely. That is a civic sense.
Yeah.
Um, in- just to just to emphasize the point, some countries where the civic sense is very high. For example, you can't even think about this in countries like Japan.
Hmm.
They would be very apologetic, and they would be caring about others. I mean, so to
Hmm.
say, that is the civic sense. Unfortunately, we need to be educated more in about that in our country, and there must be a responsibility towards others also. So that is the awareness about secondhand smoking. There must be a firm no. In public places, there is already regulatory guidelines that this should not be done, but then
Yeah.
how to implement it is the issue. Other than
Absolutely.
this, one needs to be also aware of something called genetic susceptibility.
Okay.
And if there is a family history of lung cancer, it is important. Why we want to talk about it? These are all the high risk individuals in which we think that there is a higher risk of lung cancer, and that will have a direct bearing on how do we screen these people, because
Hmm.
India is a large population. You want to screen according to the risk factors. That's why all these things become important.
Absolutely, very rightly pointed out. Okay, Dr. Beher, now how is rising air pollution influencing lung cancer risk patterns in India? Especially, let's talk about non-smokers and women.
So there were lung pollution, sorry, air pollution in metros.
Yeah,
Whichever metro you talk about is a concern. We talk about AQI index and every different parameters. But
yeah.
when we are smoking in
Hmm.
this air pollution, it is amplified. So
Correct,
I would not hesitate to say that we are living in a double standard. We are smoking 10 cigarettes per day, and
correct,
we are criticizing our government and our pollutions and city. So first of
right.
all, we should have one standard, that we should first of all quit smoking and then criticize our cities and the pollution. So
Absolutely.
it's
But
it's
Delhi NCR has been under the scanner majorly in the last couple of years, and I think the situation has become way more grave.
Yeah. So we,
And
we are smoking and we are living in a polluted city. And
correct,
and Dr. T. Raja very critically said that the particulate matters. So if the
yeah,
size of the pollutant is less than 2.5 microns, it will go inside deep into my lung parenchyma. And along with other parameters like use of tobacco in a non-smokeless form, alcohol, other hazardous environments, silicon, tobacco, other industries, and along with a genetic predisposition. So that
correct.
factor is amplified to an extent that we are very much prone to lung cancer.
Absolutely. Okay, Dr. Bajpai, let's talk about now symptoms. Which early symptoms do you think that are commonly missed, especially among the non-smokers?
I think, Divya, you brought a very relevant and meaningful question, and thank you for that. So, I would like to say that lung cancer essentially whispers first, then it screams. So, we need to really put attention on symptoms like, very non-specific symptoms like cough, like chest pain, like breathlessness. And,
Hmm.
especially if they are prolonged for more than 3, 4 weeks, one must go for imaging and appropriate imaging. Couple of times doing just a plain x-ray is not sufficient, and if index of suspicion is really high, we need to go for CT scan, etc. So I think, if there is a prolonged these kind of respiratory symptoms, I would say, then one need imaging, not a false reassurance. That would be my suggestion.
Absolutely. Okay, Dr. Mandal, now let's talk about tier 2 and tier 3 cities. Now, how can diagnostic turnaround times be improved there? It is a problem in tier 1 cities as well, but specifically so in the tier 2 and tier 3 cities.
So actually, the government also needs to put more and more emphasis on these diagnostic centers and the availability of the diagnostic facilities in the district towns and the district hospitals which they have. That is one part. So
Okay.
this our diagnosis consists mostly of, in for lung cancer at least, one of them is a CT scan or a PET scan which we do, and another is the availability of biopsy, lung biopsies. These two are the most important diagnostic tests which we require. Along with that, of course, the pathology backup is also required. So
Right.
pathology backup and the biopsy and the CT, these all three can be implemented in a medical college or in a government hospital setup, in a even a district town. So that's much feasible. And next, when we come to the advanced testing, the precision oncology testing, the molecular marker testings, we know that it is not available in many parts of the country, and we need to depend on some labs which takes the sample from one part of the country, one part of the state to the different parts. So this is a concern, and this will remain a concern also. But how can we develop is that the more number of testing we do, the more number of labs opens for this. So these things
Yeah.
can be done only as the time passes on. Otherwise, I think this is the way to go ahead, that the government needs to put more and more centers for that.
Could we say that probably the percentages of people showing up with these issues is not that large, and hence, there is not a widespread number of such centers where testing can be done available? Is that the reason?
Yes. So what you say that 10 to 15 years before, lung cancer was a disease of months. Means small cell lung cancer, you live for only 6 months and you die. Adenocarcinoma or a small cell carcinoma, you live for like that 1 year and you die. But
Okay.
now, after the advent of newer therapies, newer diagnostic methods, the ways how we precisely understand lung cancer, it has
Yeah.
also changed. So now people are also living long. So the diagnosis is also happening much more early and in many patients. So it's that the burden of disease has also increased to a great extent. Although it's right that it's not as increased like hypertension or a diabetes, it's not like that. But
Yeah.
yes, in respect to 10 years back, it's more. So I think the number of centers also needs to improve with time also.
Yeah. That's a great point. Okay, Dr. Bajpai, if you could also tell us about patients. How can patients ensure that they receive the right tests early in their diagnosis journey?
So very important. So see, we can treat appropriately only when we diagnose appropriately. So that is the standard, standard of care, suggests that, we first diagnose, then we categorize, we stage, we these days molecularly diagnose also, and lung cancer is a poster child for that molecular diagnosis. So we
Mm.
need to appropriately diagnose. Imaging is a must, as I said, imaging, especially CT scan based imaging. Then we need to do histopathology. So we need to know what kind of lung cancer we are dealing with, whether it's small cell, whether it's small cell, again some more subtypifying, and then molecular diagnosis. So there are biomarker driven therapies which are very relevant in these cases, and they are entirely kind of game changer in lung cancer. And actually, in very limited lifespan of ours, we have really seen that epidemiology of lung cancer is entirely changed because of this. So we need to
Yeah.
do those molecular diagnosis. And a lot of time in tier 2 cities or tier 1 cities, these appropriateness of diagnosis is not there. And I believe very strongly that hub and spoke model should be practiced. There has to be bigger tertiary care centers which handhold. I was in Tata Memorial Center before joining Apollo for almost 2 decades. There we
All
are
right.
doing a lot of such things. There are a couple of regional centers which are established, and we are trying to handhold them and trying to test their samples also at our labs, and providing them a fast diagnosis. So those all things are needed at different levels. I believe that, as we say that to raise a child we require entire village.
Yeah.
Similarly, for these kind of cancers we require a lot of efforts from government, NGOs, media, not only doctors and paramedical staff.
Yeah, absolutely. Very rightly pointed out. Okay, Dr. Behel, now if you talk about individuals, what should they know about lung cancer screening? But let's talk about who needs it and when also becomes extremely important, because sometime back Dr. Raja pointed out as young as 30-year-olds are getting cancer these days. So even when should it be done becomes very important.
So there are principles of screening. So the first and foremost principle of screening is that I should have a history of smoking for 2 to 3 decades.
Okay.
And the second important point is that I should be asymptomatic. As Dr. Tanmay said, that we should not have any cough, any symptom. When symptom comes, it is already established lung cancer. So
Yeah.
history of smoking, 2 to 3 decades, asymptomatic patients, and most important, a person who is willing to quit. I
Hmm.
can't do screening to a person. Screening is a low dose HRCT test, almost available in all the cities of India,
Correct.
uniformly available, very cheap test, no contrast required. Just walk in into a CT machine, get an HRCT. But there is no point doing an HRCT if you're not willing to quit. So there are three prerequisite of a screening. A patient should have exposure to smoke,
Hmm.
he should not have any symptoms, and he is willing to quit. If he satisfies these 3 points, then he should go to a nearest diagnostic center and ask for a HRCT, which is a low dose CT scan. It does not harm you, and this goes with the campaign, our campaign of detect to protect. So we
Hmm.
know that cancer can be treated, cured if detected early, and the screening process helps us to detect those small nodules which are still asymptomatic, not causing any symptoms, which my previous panelists were saying: no cough, no hemoptysis, no breathlessness, no chest symptoms. Asymptomatic individuals smoking and willing to quit satisfy these criteria, go to the nearest center. And we have started a screening program in our hospital. We say that the smokers, these corporate smokers, the
Hmm.
busiest person who is taking a break from their office jobs, going to the nearest pawn shop or a smoke shop and coming back to the work, he is
Correct.
exhausted at 7 o'clock. All these scanners are free at night. They can
Hmm.
just drop to their CT scan machine, pay as minimum as 900 to 1000 rupees, get overnight screen. So a CT scan machine is so quick in getting these CT scans that in one night they can actually scan more than 50 patients
Hmm.
without causing burden to the public or a private sector. So if that we have a tendency, you all have seen that smoking packet has a lung cancer, established lung cancer. We have seen in
Correct.
movies in between a
Absolutely.
Tata Memorial advertisement, but nobody talks about how to quit.
Absolutely.
If a same packet has a QR code that, please, if you want to quit, scan this and come to this session, come to this psycho-oncologist. Smokers have to have that fear.
Hmm.
Unless that fear of a disease is there, nobody will quit. And once, it should not be late. You have
Yeah.
smoked for 3 years, and then you realize, and you have a cough, and then you realize that I should quit. So very my next 3 words are going to be very controversial. So in my country, tobacco causes cancer,
Okay.
right?
All
In
right.
my country, tobacco causes cancer, but in
Okay.
my country, cancer cures tobacco. So
Okay.
once you have diagnosed being cancer, then you quit smoking. It's too late. Everybody, on every packet it is written tobacco causes cancer, but we all see that people who, after the biopsy, after having that metastasis or spread lung cancer, then they quit tobacco. There's no point now.
So we
So
wait, we literally wait for the bad news to be
yes,
announced before people
yes. So we
actually
have
take
to
that
be
step.
vigilant enough.
Yeah.
This topic has to come in our subject of moral sciences,
Correct.
civic sciences. So it has to be imbibed from class 6, 7, because that first smoke, when you smoke in 12th class, 11th class, or when you enter a college.
Absolutely.
That is
That
a
is the time when,
real point when you have to actually infuse in those students and that community that this is going to drain you millions
yeah.
life also, and drain, like huge economic toxicity. So once we infuse this knowledge in our young population, and we have seen Dr. T. Raja saying that India is changing. Our population is also coming, lots of young population, 20 to 30% of our population is young. If we
Yeah.
do that Japanese style, or infusing that common civic sense and a moral science that this can cause this, we will
Yeah.
be able to uh, have a change in next 2 to 3 decades. It won't happen overnight. It will require 20 to 30 years to actually bring a change in the society.
Absolutely. So largely we can say that things like probably just the atmospherical, the air quality, something which might not be in an individual's hand all the time. But you definitely know that you can tell your kids to make sure that they're not in wrong company. If you yourself are smoking, do not wait for anybody else. This responsibility has to come from within, and you have to be driven from within. Otherwise, as you said, all these things are open. You can go and get your checks done at night also. There's nothing stopping you. So it is all about taking responsibility in your own hands and
It's
acting
such a
on it.
simple, such a simple test. You do not need any kidney function test, any hypersensitivity reaction. It
Yeah.
is just beyond chest x-ray and less than a conventional CT scan. It is a low dose CT scan where air becomes a contrast, and you can detect those early cancerous lesions very early. And next day you can meet a pulmonologist or a cancer specialist or a physician. What happened last night on my scan? with
Absolutely.
with 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 a psychologist, with a psychiatrist, and it should be a comprehensive program in
Hmm.
any hospital. Rather, why not a medical college should have a cancer screening program, a lung cancer screening program, which is very much can be done at low cost with a maximum return on investment on these scans.
Absolutely. And since, as you spoke, it is the kids who start early. Okay, Dr. Raja, how has precision medicine transformed lung cancer care today?
Precision medicine has completely changed the lung cancer care. Um, Earlier, lung cancer was seen as, as I mentioned earlier, a squamous cell lung cancer, adenocarcinoma, and then small cell lung cancer, and they were treated with broad-based therapies, chemotherapies essentially. I'm talking about advanced diseases,
Yeah.
advanced stage diseases. But now we routinely do molecular profiling, gene sequencing on these patients, and we now know that in particular age group and particular histology or pathology,
Yeah.
some genes are changed or mutated, and one can broadly say that every patient is
Hmm.
different. And you can also say that almost every lung cancer is driven by something going wrong at the level of their DNA. And that's why those cells go a little bit mad and they start multiplying uncontrollably. There
Okay.
are some genes which are identified to be associated with lung cancer. For example, I mean, lung cancer physicians would talk about what we call EGFR, ALK, RAS, and I mean MET, and so on and so forth. Why I mentioned that these things is that there are individualized therapies that are developed for each of these gene changes. We
Okay.
try to target these genes and try to shut down these genes so that those cancer cells will be destroyed or they will die. And these are known as targeted therapies. And
Absolutely. So I think that is my next question for Dr. Mandal also. It is going to be about targeted therapies. So you want to further add something, Dr. Raja?
yes, yes.
Okay.
Apart from targeted therapies, the other big change that has been added on is immunotherapies.
Okay.
We use immunotherapies to rekindle the immune mechanisms of the individual,
Hmm.
which for some reason goes silent whenever these cancers occur. For some reasons, they become ineffective. So immune therapy have rekindled the immune efficiency, and then these are broadly called as immune checkpoint inhibitors. Fortunately, now there are a number of drugs that are available, and we use these treatment options. And then we also now use higher technologies to monitor these patients, how the patients are responding. We have what we call serial liquid biopsies. Uh, we,
Hmm.
we have what we call ctDNA monitoring, so by which we can predict the response early and then follow up on the response And we can also predict if the patient is going to relapse even before an X-ray or a CT scan shows some changes. We can early detect these changes. So these are all the advances that have
Yeah.
taken place in the lung cancer therapeutics.
I think that's pretty encouraging to know. Okay, Dr. Mandal, how do targeted therapies improve outcomes and quality of life compared to apna regular conventional treatments that are there available currently?
So, as said by Dr. Raja also, that we have these molecular targets like the EGFR, ALK, ROS. So, if you have an EGFR target which
Hmm.
is present in that person's lung cancer, then if you make an anti-EGFR, means just a target, and you make an anti-target drug, we have anti-target drugs which are available. So
Okay.
what happens is that it becomes much more precise. That means the normal cells of the body are not damaged. So what happens with conventional chemotherapy is that they damage the cancer cells. Also, they have effect on the normal cells of our human body. So for that reason only, we have this anemia, the low WBC counts, oral mucositis, diarrhea, which is commonly seen with the conventional chemotherapeutic agents which was used earlier. But
Okay.
after these targeted therapies, this normal cell damage is much less, or it's actually nil. So this leads to a better option, that the side effect profile is much less and you are much more precise. That means you are much more actually targeting that part of the organ, or that part, that those cells only, which expresses those anti these targets. So it becomes
Yes.
a much more precise therapy. So as we were also talking, that precision, it's the day of precision medicine. It's actually the day of precision medicine.
Yeah, I think that's excellent for sure. Okay, Dr. Behr, also tell me what should patients living in smaller towns know about accessing specialist lung cancer care?
Yeah, so everybody, as Dr. T. Raja said, that everybody is actually addicted to mobile phones.
Yeah,
Everybody is addicted to social media. So
correct.
we should have a policy from our government side, and a public partnership and public-private partnership. You said we should have those educational reels. We
Yeah,
have reels and shortcut videos on YouTube's. Why not every we have advertisement who have to come before any YouTube video or any, so that a screening program, an educative lung cancer program, how to, so 3 points: you're smoking, you're willing to quit, and you are asymptomatic, get yourself screened at the nearest cancer center or a nearest center. That is
correct.
the 10-second video, which should be a compulsive video, and I'm talking about across many cancers. So when
Absolutely.
this will become our habit of watching over social media and whatever is our routine, so then
Hmm.
it should have every metro, every train should have a mandatory this hoarding. You
Yeah,
cannot have three hoarding. You can have three advertisement and one advertisement on the public health area as well. So once we change our policy, it's a Niti Aayog subject. So once we change our policies, then we will imbibe and infuse this knowledge into our community. That's very important.
absolutely. I think great points there, and I hope somebody from the government is watching this and it reaches the right ears. Okay, Dr. Bajpai, now let's talk about lifestyle factors also, which are very important. We have diet, we have exercise, and avoiding pollutants also. Now, how does all of this impact the treatment outcomes?
So I think again very important. So I would say that it's a comprehensive program, or it's a when we say that management alone, so drugs alone cannot take care about everything, but drugs are very important. I also want to give this message loud and clear that alone lifestyle modification also doesn't solve, because these days I'm also seeing some dangerous pattern. At times patients are just delaying their things and they're saying, I'm on some ancillary therapy for 6 months, I will give this try and then I will come forward, because they have lots of myths about the cancer chemotherapeutics, or the newer targeted therapy, etc. So I want to make this very clear that lifestyle modification is very important. It is part of the comprehensive program what we propose, but it cannot substitute the main treatment. So it is an adjunct. It helps a patient to cope with what treatment we are giving, with the diseases and when many other things, and very important, but we must not substitute it. And also, early detection is very important. Similar time, right treatment at right time. These all appropriateness is extremely, extremely important. And many times because of lack of awareness, these patients, they get treated for TB, they get treated for some other infections, and as such they got delayed. And when they get diagnosed, there is denial, completely denial, and then they continue to take some inadvertent treatment and then come on the main treatment. So I would say that this tendency should be curbed. Lifestyle factors which are very, very important is to decrease the stress in any form. Stress is the major killer, I would say, not only for cancer but many other diseases. It's very, very important and
True that.
very difficult to measure it also. So basically we don't have a direct metric. We cannot, it's not a lesion which we can measure, so it's very difficult. And stress levels are exponentially increasing. In very early, even the younger kids, they are so stressed these days. And then as you grow in your profession, your other things, those
Yeah.
stress come accumulate. So I think something needs to be done really on a very urgent basis. It's no longer a joke thing, it's a reality, and we have to really act on this together. And I believe again, there is an importance from government side, from NGO side, from media side, from doctor side, and all social activist side, because this is the major one factor which can really improve many things, including this. And the people who are in my humble couple of decades career, I really have seen the people who are with less stress, who are having
Mm.
better coping mechanisms, support system. Their acceptance is better, and when they accept the disease, their treatment path is much more easy, and even their outcomes are better. Their toxicity patterns are much less. So I think this decrease in stress is paramount importance. Then addictions, we are talking about tobacco in any form, it is hazardous. Many
Yeah.
people these days are thinking that it's only the crude BD or cigarettes which are bad, and they feel that e-cigarettes are very safe. Very dangerous trend, especially the teenagers and couple of educators. They don't want to rely on that. No, this can also be hazardous. So I think this message should be very clear that tobacco in any form is hazardous. Only the site of disease might change a little bit, but it is cause.
Vaping has become super cool. You have people
Yeah.
I have seen who will sit and they'll lay out their variety of vapes, lovely colors they come in, lovely
Yes.
smelling, and I think for a non-smoker they get out of this space literally with a hangover without having smoked at all.
Exactly. So I think these things needs to be, incorporated in the curriculum, incorporated into day-to-day things. And as Ankur also suggested that, why not, when any catchy TV program or anything is going, why not to incorporate a little advertisement, little reel, which people see. And, when, it is definitely a mind's tendency, when you see something more often in different manner, then, you try to believe, and initially there is a denial. And other factors are definitely tobacco in any form, alcohol. Again, there was lots of talks about moderate alcohol, this alcohol. Other people try to take reasons, how can they take it? And there are differences of opinions and different suggestions. I would say that alcohol, tobacco becomes synergistic for many things, so one must really try and avoid these things.
I
And
think they're
then,
best friends. They go together a lot. That's what
absolutely.
you usually see. Mostly smokers will definitely, and a lot of people you will hear saying ki, with a drink it's required. Only when I'm drinking, I love to smoke. So that also is there. Yeah.
It's very sad to see, our young generations, or even a couple of other people also in our country, they don't know any other way of celebration. Wherever there is, they just want to, take a wine or beer or whatever, and they feel that this is the mode of celebration. I think we need to work on this. We are very culture rich society, and we need to value our systems. And I
The
believe right from the
glorification
very
maybe
beginning.
needs to come down. The glorification needs to come down, and the reality needs to, be communicated very strongly on every platform possible.
Right, peer pressure. So I think this is also very important, that somebody doesn't want to take, then people pressurize him or her so much, and rather kind of make fun of it. So I think if in our value system we kind of start celebrating other ways and celebrating the individuals who are not into that, then perhaps we can strengthen the this part, and we can really avoid these factors.
Absolutely. As they say, charity begins at home, and all of us can at least try. in
Absolutely.
little spaces. Okay, now let's talk about now this. Now the following questions are.
I will take 20 more seconds. One important healthy habit I would say is to go for screening. This is also a habit. This is essential. It is not something a luxury or so. One must come that, as we take that, we have to pay our insurance bills, we have to pay our electricity bills, we have to screen ourselves. And that's what should be a lifestyle habit.
And probably, can we say that somebody should begin in their 20s? Is that a good time? Mid 20s, maybe? Or
So see,
earlier?
it again depends
Dr.
upon,
Bahl is shaking his head.
so see, the
That's
customary
also
thing is
that's
that, if somebody is a smoker and for a couple of decades exposure, etc., that was the, the standard teachings. But these days, because we are seeing, especially in India kind of countries, that lot of women, lot of non-smoker and lot of, varied patterns of cancer. So I would say that, we definitely need to decrease our threshold, decrease our age of incidence, and, try to, because it's a very simple, small test. I
Hmm.
think we need to be more liberal with our screening age, with our
Yeah,
screening population.
right. And okay, but Dr. Raja, once again, what questions or aspects should the patients discuss, with their treating physician once diagnosed with lung cancer?
Absolutely. Awareness is the strength. Knowledge is the power in this, in this current day and age. The
Yeah,
patient should be involved in the treatment. Earlier, patients are usually very, very, afraid of the term called cancer, and
hmm.
then they wouldn't want to even hear a diagnosis of cancer. But I
Yeah.
think things have really changed.
So
Patients
today
are now.
also people are pretty scared. I think you're probably a little bit more hopeful, but I'm sure that there's a deep-seated fear that is there the minute you hear of cancer.
No, what I want to add is the
Yeah,
fear is still there,
yeah,
but the tools to face the fear has tremendously improved.
right,
And nowadays, with the availability of the internet and access,
correct.
knowledge has given a little bit of courage and a more refined way of facing the malignancies and cancer. That's what I would say. So
Yeah.
what should the patient do? They
Hmm.
should be engaged in the treatment decision making, and that's what one can say. They should
Okay,
ask the doctors what is the exact pathology diagnosis, what is
okay.
the molecular subtype of my cancer, is there a particular genetic mutation or something wrong at my genetic level,
Yeah.
and can you please do gene sequencing to understand more about my cancer and
Hmm.
what is the stage of my cancer? Is this a curative intent therapy or is this a palliative intent therapy? Are there options to treat my cancer with targeted therapy, immunotherapy? And what they should ask about what is the overall plan, upfront planning, and then they should be also asking about what is my expected survival or response rate, and
Okay.
what will be my quality of life. They should definitely ask about cost and whether insurance will cover. These are all
Yeah,
very important. And then
absolutely.
they should also ask about nutrition and if at all there is a need for palliative care. So there is
Hmm.
a whole range of things. A good discussion will give them enough mental strength
Yeah.
to face the malignancy and the treatment, and they should understand about the side effects so that they can adopt themselves well and cope up with the treatment and get the best out of the whole effort that's going on here.
Absolutely. I think that's fantastic, and I hope my viewers are jotting down these points because I think it's a nice blueprint kind of to carry because many of us are just not aware what to ask. So this will be a great help. Okay, now I have a few questions which are for all of you. So please feel free to answer as and when. Okay, looking ahead, what single change, probably Dr. Mandal, you could begin. What single change could most significantly improve lung cancer outcomes in India? And let's talk about over the next decade.
So I think over the next decade, we need to come ahead with a screening program, the low dose CT scan, which is actually not feasible in a country like India because it's a lower middle income group country, and low dose CT scan is not that much cost effective to our situations. But I think we need to sort out methods by either using the AI or any other method so that the cost of low dose CT comes down and we can implement it as a screening program. That is what I want to see in the next 10 years happening in lung cancer.
Okay, great. And Dr. Raja, what would you say? A single change that could most significantly improve lung cancer outcomes?
How can we change the whole scenario of lung cancer? If
Yeah.
prevention is possible, that will be the best option. Cancer should not happen. That's the best approach. For example, if we can completely stop smoking, not just reducing smoking or abstain from smoking, whether we can completely stop smoking
Yeah.
and tobacco related habits, that will be a big plus. And
Yeah.
then the next best thing that can be done is, if we can detect the disease at an earlier stage than a later stage, that's
Mm.
when the screening comes into the picture.
Right.
And you can't screen the entire population. It's impossible with such a big
Absolutely.
population of our country.
Yeah.
But we can do what we call targeted screening or high risk screening. That will be cost effective, and we can pick up more number of patients at an earlier stage. The third most important thing is awareness. At the
Mm.
primary care level, at the general physician level, if there is an awareness that if there is persistent symptoms, a high index of suspicion of cancer,
Yeah.
then if they can network with cancer doctors as early as possible, if there is
Mm.
a referral pattern, refer to a specialist. Those
Yeah.
things are very, very important in getting the best outcome in these patients.
I would
Absolutely.
suggest that there's a screening program, national comprehensive screening program, or a guidelines. Unfortunately, lung cancer is still not in the screening programs of the country. We have breast cancer, cervical cancer. Lung
Yeah.
cancer is still not in the national guidelines. So, first of all, the policymakers have to emphasize that lung cancer screening should be incorporated in our country. There are various continents in America and Europe. This is a part of the screening program. It is still not a screening program. Second
Yeah.
thing, that every insurance, I give a top up premium of my insurance. Next year, insurance will not be renewed if I have
Yeah.
not got my screening packages in Middle East and in UAE. If you have not done some test in a year, you won't be entitled to get a next year. So that saves a lot. If I'm investing in my screening program, if I'm investing $10 in my screening, I'm saving $1,000 on my treatment. So this concept has to be introduced into our insurance policies, that if you have declared you're a smoker, your next year insurance will not be put if you have not done an HRCT test, which is just 900 rupees test or 1000 rupees test. So policy makers have to understand that we are not living in a old age. We are entering into 2030s and 40s. So we have to change. India has to change also.
Absolutely. Dr. Bajpai, would you like to add to this?
Absolutely. I believe, it's essentially a continuum of care. The biggest mistake what we do is that understand cancer is a one-time event. It's
Mm.
not, essentially because it's a continuum of, chain of events,
Yeah.
and it affects right from the diagnosis, rather pre-diagnosis till very, very late, and even the families around. So we need to work very early until late, handhold. So I believe that, lifestyle modification, first thing, non-inflammatory lifestyle, what we say, calm, food habits, sleep, and addiction limitation. What I just discussed. From there, screening, very regular screening, how to implement, how to enhance. There can be many measures. Some of them I've already suggested. So screening,
Yeah.
then early detection, and then awareness that even if it is late, then better late than never. So please come forward, because we have there right now. Really, we are in an era where there's so much targeted therapy, so much immunotherapy, other things. We can really make a change even if this is advanced stage. So that message should also go, because there is lots of myths. If there's advanced stage, it is a death sentence. It is no longer true. And then after that, survivorship. So then, because our aim is not just treat and then send them. Our aim is to really ensure that they should go back to normal lives. And people are very afraid. They become very negative, and with this diagnosis, it is a bad news. Truly, I think we need to incultivate in their minds that cancer is also one of the chronic disease like diabetes or blood pressure, and you need not really hide this diagnosis from your peers, from your social groups, and you should feel positive, get yourself within this chain wherever applicable, wherever most appropriate, and then go back to normal lives. So if we
Yeah.
can ensure that part, and really can work around together, then perhaps, we can really make a change.
Absolutely. What everyday habits can help people reduce their risk of developing lung cancer?
Completely avoiding smoking or tobacco is probably the biggest healthcare change that we can bring about in our country. And the other thing is second-hand smoke. As we mentioned earlier,
Yeah,
passive smokers. There are people at home, women, children, who get exposed to smoke. And then in workplaces and in our offices and in
correct.
public places, we should be very, very sensitive about second-hand smoking. And then
Absolutely. And
something
and
very,
there is a big discussion as to, even in the corporate space, the smokers have an edge because they get to get out and they get to, have these discussions where the non-smokers are left out. So I think there's a lot of peer pressure also that comes with smoking, not only in school and college spaces where we also see a lot of kids falling for all of this, but also in, grown-up spaces where people are well aware of the damages and still they go ahead and do it just sheer out of peer pressure.
you are absolutely right. Unfortunately, in the Western countries, actually, the smoking um, prevalence is beginning to come down. They
Yeah.
are increasingly understanding that the smoking is not a hep thing anymore. If only we can inculcate that particular message.
Yeah,
Smoking is not a hep thing. It's actually a bad thing. If only we
absolutely.
can broad base that message. The other
Yeah,
thing is early, warnings and being aware and regular health checkup. Those things will be helpful. And then being aware of what we call outdoor pollution and indoor pollution. Clean cooking fuels are very, very important.
yeah.
Um, that's something that can really change at the domestic level. And healthy lifestyle. We call it as anti-inflammatory lifestyle. Regular
Hmm.
exercise, avoiding
I
alcohol,
think that's a great blanket term. That's a fantastic
anti-inflammatory
blanket term.
lifestyle.
Yeah, yeah.
That is also very, very important as regards to lung cancer. These
Hmm.
are all things that one can do on an everyday habit that will have a big change in the incidence and outcome of lung cancer.
Right. Dr. Mandal?
So I already spoke that I completely agree with what Dr. Raja said, that it's of course avoiding tobacco in all forms and also the second hand smoke. I think these two factors are the most important factors which should be looked upon, and it should be avoided at any cost.
So I would suggest that watch your peers. If
Hmm.
Divya, you're watching your peers and you're stopping your peers from not smoking, that would be
Correct.
a wonderful habit. We criticize our peers. Be with your peers and ask just to educate them, and do not be negatively educate them, just positively educate them. Hey, Mr. Ravi, please don't go for this thing. And if you're going, we have a psychological aspect. We can help you in quitting this tobacco, smoke less or smoke form. So this should be a habit in our corporate. I should get brownie points for that also.
Absolutely. And have enough self-confidence not to step out with people who are smoking. It's okay.
Yes, absolutely. Yes.
Absolutely.
Right,
Dr.
avoid peer pressure. I would say avoid peer pressure, and also so pollution, secondhand smoke. I think that is also very, very hazardous. I'm not smoking, but I'm getting it. One must say a very big no, and there has to be some strong steps for that. And similarly, there are different challenges in rural area, urban areas. Rural areas, even today, I'm seeing couple of women, they are getting exposed to that, smoky chulas, etc., which can be easily, kind of removed. So I think all those
We have
things.
wood-fired ovens even in the urban setting these days,
Yeah,
which is
exactly.
very
So there is
popular.
different trends, and I think we need to understand these are risky patterns, and we need to work on that.
And we again have to deviate ourselves to the nature.
Hmm.
I have started in my practice. I don't prescribe fancy multivitamins or gummies and all those things. I just ask my patient to have 100 gram of fruits daily, 100 gram of tomatoes daily. They are the best antioxidants. So we
Okay.
have to. So we have to up nature. So we are vaping in the evening, and then we are going to the work, and then next morning we are criticizing our AQI. You're vaping, you're taking smoke inside your lung, and next day you are saying that the AQI of New Delhi is 500. Oh my God, moderate risk or a yellow alert. So, antioxidants, fruits and vegetables, healthy walk. So, these all a balance is required rather than just preaching all those things. So, moral civic sciences must adjust your peers, give positive notes to your peers, lots of fruits, vegetable, good sleep, as Dr. Vajpayee said.
Yeah,
So
yeah.
make a habit of all these things.
Okay.
Yeah, as much colorful plate your food, your plate should be as much color. There are multiple greens, multiple yellows, multiple reds. That's what I said. They said what also. I said you just ensure that there's very colorful plate you're eating. That
Yes,
much.
yes.
Absolutely. Okay, now let's talk about something which is very important and still a lot of times not given enough, leverage. What emotional and psychological support options are available for patients and families?
The first support is family.
Yeah,
Um, Family is the biggest strength for anyone.
right.
So family counseling is important, and
Okay.
then individual counseling. And we have what we call in hospitals we have what we call patient support groups
Yeah.
or patient related oncology,
Okay.
social workers. We in some hospitals in tertiary care hospital they have what we call psycho-oncology divisions. So
Okay.
these are all there. That's very important. Apart from that, we should also talk to the patients about their financial health,
Hmm.
getting back to work, and vocational support, and then trying to talk to their companies or employers. I mean, how
Hmm.
to support the patients for their financial health, and also, I mean, adequate and timely leave options. All this is important.
Yeah,
Integrated support to get the best outcome.
absolutely.
NGOs who are working in the
Yeah.
space, and I think that's very very important because as very rightly said, it is not only the patient but the
Hmm.
family or the caregiver, they also get burned out. So we need
Correct.
to understand that, and because this is again a long, generally therapies go long, and then the aftercare also go long, so we need to really work on. And while you're breaking bad news also, because this is possible in a doctor's life, that this is the thousand case which you are diagnosing or which you are saying that this is the cancer, but in that patient's or family's life, this is the first time that bad news is coming. So learning to break bad news is also an art and science, and it should be done in the presence of social support, NGOs and other things. Where are the coping mechanism? I have seen many highly educated robust people, very confident, and they are kind of becoming very shaky and almost kind of devastated with this kind of news. So it has to be very gently and appropriately delivered. And then we need to ensure there has to be support groups, because patient feel comfort with the peer groups who has already gone through this kind of journey, or who are in the journey somewhere. And when they see that, oh, this patient also was the similar stage 3 disease which I am having, but now this patient is getting cured, or this patient is already a survivor, that gives a tremendous amount of confidence. So I think these these kind of journeys needs to be shared. Support group, NGOs having tremendous importance. Media, I believe that media is extremely important. These kind of webinars, social, this carries a lot of awareness things, and this should be multiply happening. It should not be also a date driven like World Cancer Day or Breast Cancer Day. It should be again a continuum, and we keep revising these things.
Yeah, that's very important. Dr. Beher?
So it should be no cancer day celebration. First
Yeah.
of all, not an individual organ-based cancer. Second thing is, as Dr. Bajpai rightly said, taking care of the caretakers.
Hmm.
We always talk about patient. We
Yeah.
have to take care of the caretakers because the domain is shattered, the families are shattered economically, financially, socially, psychosexually, everything. So we have to take care of the caretakers. A
Yeah.
tendency of every comprehensive cancer center to talk about survivorship, because in community there's a taboo. Cancer means death sentence, so we have to show them light beyond the tunnel, the survivorship things. And I echo with Dr. Bajpai. She has rightly said that calm down and
Hmm.
do not die before you die approach. So
Yeah.
do not die. मरने से पहले नहीं मर सकते. Do not die before you die. And in this era, we have huge survivors. We have success stories. So we have to show all our patients our success stories, because they hear death from the community, from their advisors. We healthcare providers should have a tendency to show them survivorship, and what US, Europe, and our Western clinicians are treating, all is possible in our countries. And that's why we are becoming the medical tourism hub for many part of the world.
Correct.
So all those things needs to be discussed. A ray of light has to be shown, not sense of impending doom which they come from the community.
Correct. And as you very rightly said, the whole viewpoint of being the taboo needs to be shifted from the cancer to probably smoking and other things which directly lead to it. Okay. Also, if Dr. Raja, you could tell us what role can public or private partnerships play in expanding access to advanced diagnostics and targeted therapies?
Public-private partnership can play a big role in expanding the access to the diagnosis and therapeutic option.
Yeah,
And I mean, for example, it's impossible to screen the entire country unless you develop a infrastructure across the country,
absolutely.
right from government hospitals to tertiary hospitals.
Hmm.
If only a low dose CT scan can be made available. And then
Yeah,
once the diagnosis happens, we always look at gene sequencing for these patients. But
correct.
good labs are not available in all the places.
Correct.
So it's also important to probably establish regional genomic referral centers. For example, every state can have
Mm-hmm.
one good genomic lab, and
Okay.
that lab should provide testing, if possible, at subsidized costs, and that will be very, very helpful. And then nowadays we use a lot of advanced drugs called targeted drugs and immunotherapy and so on and so forth.
Mm.
But these drugs are not easily available to every patient.
Okay.
Unfortunately, cost is an issue,
Cost.
and our social economics is also so drug access programs. Some of the companies are and some of the programs are offering what we call patient support program, drug access program. We
Okay.
must broad base those things, and if possible, develop a national lung cancer registry. These are all the things that can be done at a larger scale, and that can be done only by a public and private partnership.
Absolutely. I think that was very well explained. Dr. Mandal, would you want to add something to it? We were
I think
discussing the role
I
that.
think I think Sir has explained everything in total detail, and it's really a blueprint which everyone needs to jot down. Which you said earlier also, that before going to any place, you can well take this as a good note for asking questions or clearing your doubts. So this is actually what is needed and it's the need of the hour, to reduce the burden of the disease.
And I think the amount of stuff that you've explained, Dr. Raja, it is easily, I think, if the conversation has begun, so by the time all of this will happen, I don't see, I see at least 10 to 15 years anyways going into the process till it really goes down to the grassroots or the smaller cities. Or you think more time will be taken?
No, no, I really believe
Yeah,
that India is a great country because
absolutely.
just talk about cell phones. Uh,
Yeah,
20 years ago, I did not have a cell phone, but you would agree with me that every Masi and every vendor and
yeah,
everyone is having probably not one cell phone, two cell phones now,
absolutely.
and phone pay and is all very common terminal. How did that
Even
happen?
for the smallest payment, where you don't have the excuse that you're not carrying change, because everybody has, even outside the temples, you just buy a few flowers and they will be having Paytm. So, or UBI basically is so prevalent right now.
Absolutely. So these changes, I
Yeah,
strongly believe, I mean, India somehow, I mean, the maybe there is a difficulty to begin with, but once it starts, we leapfrog.
Yeah.
So that's the strength of our country. So it's not going to take a long time. I strongly believe it will happen in real time, quick time, and
Okay.
I mean our country will will catch up. I mean we'll be at par with anyone very soon. That's what I strongly.
Absolutely. I'm a firm believer in that. So, absolutely.
Public, I would say public, like our institutes, AIMS, PGI, and Tata Memorial, and many other institute, people listen them. They are the gold standard.
Correct.
And the private, and everybody knows that what private health system is doing. They are giving a class and technology and availability, emergency services. So both are required. Nation requires both, so people have to listen. Public and private can implement and execute it. So once they are talking to each other rather than criticizing each other, I always acknowledge and appreciate my temple, which is All India Institute of Medical Sciences. but
Yeah.
but they have to acknowledge Fortis Cancer Center or Apollo or Max and all those private partnership. Once we are on table, then who will benefit? Our patients will benefit. So
Yeah.
policies, it's not the public doctor should make the policies. The private doctor should also have equity in that deciding, and flight of ideas and technology and all those things. So once they are on table, community and patient will get benefit.
Yeah.
So completely, I think public-private partnership alongside, I would say, industry and academia partnership. We should not be just shunning away from industry, because the progress will happen when all of us join hands. And ultimately, we should be conscious and cognizant that we are working towards patients and towards advancing science. So when motto is really clear, every partner is important, and every contribution is extremely important. 1 plus 1 is not 2 here. 1 plus 1 make 11. And I believe collaboration is the key. With collaboration we can really succeed in within nation, within our with institutions, intra institutions, inter institutions, and international. I would say मैं लास्ट में एक हिंदी में एक लाइन बोलना चाहूंगी जो आई एम रियली पैशनेट अबाउट, एंड आई ट्रूली kind of go with that, that
जी.
ये दुष्यंत कुमार की पंक्तियां हैं। तो कौन कहता है आसमां में सुराख हो नहीं सकता, कौन
Hmm.
कहता है आसमां में सुराख हो नहीं सकता, एक पत्थर तो तबीयत से उछालो यार।
True that. So, okay, and now let's talk about the gaps that exist in awareness and training around lung cancer detection at primary and secondary care levels. So, Dr. Mandal, would you want to begin with answering this question?
So there are gaps everywhere, which we see in the primary and the secondary levels. Of course, it starts from the awareness that it starts even before the awareness that we need to know that smoke is not helpful, smoke is injurious. So say it begins from that part of the topic, and then comes the awareness camps and the no smoking campaigns which we have.
Correct.
There also gaps exists because the government and the private both needs to participate into much more strong awareness driven awareness driving programs.
Yeah.
And next comes to the diagnostics. If you ask, yes, in the second tier and the third tier level the diagnostic needs to improve. And the next part is the drugs or the availability of the newer agents also, that also needs to be available in the first and second tier city, and it also needs to be provided with the different patient support programs which are available. So there are gaps at every level, I think, which need to address each and every one of them. And in due course these gaps should be addressed, and of course we should see a bright future in this.
Great. Dr. Raja, would you want to add something?
I agree with what Dr. Tanmay said. The other thing that I want to point out in India is that in India, tuberculosis is still a very common disease, and chronic pulmonary disease, what we call COPD, is also a very common disease.
Okay.
So many times the symptoms are attributed to tuberculosis or a chronic lung disease, for example, asthma and so on and so forth, and then it gets missed. I mean, from a quick diagnosis. So there must be a very high index of suspicion among the general physicians, family physicians,
Correct,
and
correct.
primary physicians, so to say, and then awareness that low dose CT can be done, and then the other thing that is a big difference in our country versus a Western country is what we call a referral pattern,
Yeah,
integration into referral network. We have a strong general physician presence all over the country. Every nook and corner is blessed with doctors. But then
correct.
once they pick up once they have a suspicion, they should have a network to refer to the specialists. That's known as integration with networks. It could be a referral to cardiology, it could be a referral to oncology, it could be a referral to pulmonology. So these are all the things that are still can be considered as a gap in our country. Hopefully,
Yeah,
things will improve.
So the first and foremost gap is that our peers who are sitting at village level, panchayat level, district level, city level, major city level, and the capital level, and the centers of excellence like Tata Memorial, AIMS, PGI, and various comprehensive cancer center. There should be a chain of right information and I would say a sense of responsibility towards a physician sitting in a very remote area, that every so we are all connected by internet. So now we don't have to travel miles to get a Tata Memorial or a All India Institute. They are sitting. The oncology is so much increasing that every center is having, so that's increasing and that will increase day by day. So we have to connect to our peers in at that level, and that will actually help us in bridging that gap of lack of
yeah,
awareness, treatment, and every chronic symptom. So we talk about 6, 7, 8 symptoms, warning signs. So I say that any chronic symptom could be cancer, and ask your physician that can I have cancer. So then his eyes he will raise his eyebrows. Yes, it could be. So once we are teaching our peers, teaching is I'm also getting taught daily. I read daily. So there's no egos among doctors. We need
correct.
to bridge that gap and bring every doctor on a table, at least try that, so that the lag and the lead base and the lag base is shortened, and every patient deserves the right treatment.
Absolutely. Dr. Bajpai?
Right. So I would say that, again, pandemic has made us really wise, and telehealth, artificial intelligence, all these, which are really tools, they should be appropriately used. Again, I'm saying they are tools. So one must understand they cannot replace human, and they cannot replace the clinical context, but we can take help of them because there is a lot of cost saving, there is a lot of manpower saving. And with all these measures, perhaps we can really establish and we can provide the last patient sitting in the remote area also that kind of a care. And I think for our peers also, I would like to say that be open. There is no harm in taking information, taking help, because ultimately we all are working for our patients, and this is extremely important. Again, towards end, I would say that glass is always half filled or half empty. And I
Mm.
say all the time to my patients that, I want from you a positive attitude, because I'm very positive. I never give up. And whatever is the situation, I say that, in this situation, I'll try to do the best available thing for you, and that's where you have to be with me. And the first step in this is acceptance, then follow the thing as a protocol. So, when they really remove that emotional baggage and accept that I think, and remove that why me thing, because that creates the lots of agony, and move in the space in right directions, I see many times even miracles do happen.
Absolutely. So Der hai Durusta is also extremely important. Doesn't matter how late you there. Once you there, you better handle it in the best fashion possible. Absolutely. I think on this note, let me thank all of you again. It has been a very fantastic and a great eye-opening discussion, and I hope all the viewers have also so much to take away from this. And as you all have very rightly said, I think all the fingers and the thumb together is what make the fist. So we have to all get together and attack this problem.